Good evening. Good evening. My topic of our presentation is role of radiological imaging in cerebral Hydatid. Introduction. This is parasitic infection which caused by tapeworm larva of two Echinococcus species, Echinococcus radiolosus and Echinococcus multilateralissus. Epidemiology. This disease is endemic in Middle East, South America and Australia. It is important that this condition also seen in non-endemic part of the world because of the rapid movement of blood from endemic to non-endemic areas. Liver and lung are involved most frequently. CNS involvement reported in 3% of cases. Pathogenesis blood from water carnivores are definitive hosts which are intermediate hosts. Women are affected by accidental ingestion of food or water contaminated with blood fecal matter containing tapeworm. Clinical feature. The growth of Hydatid is usually slow. Usually these are asymptomatic and clinical manifestations are caused by compression. The consequence is raised intracranial pressure that results in headache, nausea, vomiting and seizure. The diagnosis of Hydatid relies on serological test and imaging technique. Imaging feature. Neuroimaging of Hydatid disease is characterized by well-defined oval mass and drain tissue open in territory of middle cerebral artery due to its embolic nature. On CT, visually demonstrate internal fluid similar in attenuation to CSF and isotope hyperdense. On MRI, cystic echinococcus is caused by echinococcus infection. This is more common and demonstrates internal fluid isolated to CSF on all sequence with a smooth, thin, well-defined T1P2 hyperintense wall. Although most cysts show no enhancement, partial or complete ring enhancement is occasionally seen. Most cases demonstrate no surrounding edema unless the cyst is superinfected, helping its differentiation from abscess. Rarely calcification or daughter cyst may be seen. Multiple cysts may result from rupture of solitary cystic lesion. Familial echinococcus is caused by Echinococcus multimodularis. It is rare. It can be congenous. The lesion demonstrates a semisolic structure with multiple vesicle in a dense connective tissue trauma. Calcification and surrounding edema are more frequently seen. Aims and objective of this paper is to describe the characteristic feature of cerebral Hydatid disease in computed tomography and magnetic resonance imaging. Early diagnosis help in early intervention and treatment, which result in better prognosis for this patient. Method. A total of 5 patients with cerebral Hydatid disease were imaged at our institution. The finding of CT and MRI were retrospectively evaluated. The CT examination were performed on 2 CT scan with revolution exam, lift MTMs, CT256 and MRI examination were performed on Siemens magnetron vision plus 1.5 test function. Case 1. A 63-year-old male patient presented with complaint of change of voice and reduced nerve movement. Answers of the brain, we can see the hypodense lesion with surrounding hyperdense rim and antecedent vasogenic edema. On MRI correlation, T1 weighted axial image shows a hypointense cystic lesion with internal septation. T2 weighted image shows hyperintense cystic lesion with internal septation and surrounding perilesional edema. Diffusion weighted image shows no evidence of any significant diffusion restriction, and T1 weighted post-contrast axial image shows peripheral thin rim of contrast enhancement. Case 2. 18-year-old boy with headache, nausea and vomiting. Axial unenhanced CT image show lesion with septated solid component and calcification. Septation is clearly seen. Axial T2 weighted MRI imaging shows a large hyperintense multiseptated cystic lesion with solid pores and punctured calcification. Axial T1 weighted MRI image shows large multiseptated cystic mass with solid shallow portion, and post-contrast T1 weighted image shows the incomplete ring enhancement at fairly contrasted solid component. Case 3. A 42-year-old patient with headache. Axial T1 weighted MRI image shows hypointense signal similar to CSF CT. The axial T2 weighted MRI image shows single hyperintense lesion containing septation, and the post-contrast axial T1 weighted imaging shows no enhancement, while diffusion weighted imaging shows no evidence of diffusion restriction. Case 4. A 48-year-old male patient presented with headache. Axial T1 weighted MRI imaging shows the hyperintense signal very similar to CSF, while axial T2 weighted MRI imaging shows hyperintense signal containing two septation. Post-contrast axial T1 weighted imaging shows no enhancement, while diffusion weighted image shows no evidence of any significant diffusion restriction. Surgery is the most effective treatment for echinococcal infection, but the integrity of the wall should be maintained to prevent anaphylactic reaction. Treatment with anti-immunity therapy is also effective. Result. CT and MRI imaging in combination are helpful in diagnosis of peripheral hydatid disease. Although CT is superior to detecting calcification of the cyst wall or septa, MRI is better in characterizing the lesion, defining the anatomic relationship of the lesion with adjacent structure, and help in surgical planning. When a well-defined spherical cyst, intracystic intracerebral lesion with obvious mass effect but no surrounding edema, no contrast enhancement detected on CT, hydatid disease should be taken into consideration. If peripheral edema and thin rim enhancement are observed, either complicated hydatid cyst or other cystic lesion of brain should be considered for differential diagnosis. Characteristic CT MR of multilocular cystic alveolar open focus should also be removed for differential diagnosis. Discussion. Cerebral hydatid cysts are benign as slowly growing cyst. The lesion is initially asymptomatic. When it becomes larger, it may produce pressure symptoms like headache, vomiting, nausea. Lesions of cerebral hydatid disease are usually distributed in the cavity of middle cerebral artery, especially in the parietal lobe. Most of them are in supratentoric region. Multiple cerebral hydatid cysts are rare. It results from spontaneous traumatic or surgical rupture of solitary primary cyst or as a consequence of cyst rupture elsewhere and embolization of hydatid to the brain. Patients with cerebral hydatid cyst may have the cyst with the other organ, but CT and MRI demonstrate a spherical, well-defined, smooth, thin-walled, homogeneous cystic lesion with full density similar to CSF with orbital separation or calcification. The cyst wall visually show a thin ring of low signal intensity of both T1 and T2 weighted in the presence of daughter cyst is considered pathognomic, but it has been rarely reported. Compression of the midline structure of the ventricle are seen in most of the cases. Surrounding edema and ring enhancement are usually absent. Cerebral lateral echinococcus is rare, and in CT and MRI it appears solid, semi-solid or multilocular cystic mass with definite margin. Calcification and surrounding edema are common. Contrast enhancement after within the region of inflammatory reaction around the cyst. Differential diagnosis of ornithogenic cyst, erignosis, cystic tumor of the brain, biogenic abscess, cystic metastasis. These are my references. Thank you.